If you want to come on camera, go on screen. We've got a few questions from the audience, and I'd invite more if you enter them in the chat. So thanks very much for those illuminating presentations. I think the message I take away is work is happening. And I know that Michael McGinnis started the learning healthcare system. I do believe we are learning. Progress may be slow, it might be uneven, but I think what you heard from our three speakers is going from where Mai started of the elucidation of at a high level of where we need to go. There are examples of positive deviance happening across the country, right? In a venture-backed organization like CityBlock, happening at Optum, Blue Cross Blue Shield North Carolina through the Center for Medicare and Medicaid Innovation, in Medicaid with long-term social support. So I think what I'm struck by is an optimistic that things are happening and that we are learning. So I want to start with, I'll ask a couple of questions and then we've got from the audience. But my first one is, what struck me is, it feels like wherever we are, there'll be a combination of community and population-based investments and individual. So Patrick and Piyush and Sharon, you all spoke about things that required a combination of whether it's for infrastructure, data infrastructure, or other things. There is a set of enablements or population or community level investments that need to happen. And then obviously we talked a lot about value-based payments, right? So it's a both and situation. If you could talk about who should be making those payments, how do we interact between them? Because it feels like that is a very fruitful area to explore and to learn from.
I can start, others can jump in. You know, if you think about the basic financing system, I mean, other countries have flipped the model from what we have, and they have a much more robust social determinants of health, social safety net financing mechanism. And, you know, on average, they get better health outcomes at a lower healthcare delivery cost than we do, and just better health outcomes. So that would argue at a federal level, we should think about flipping the model. You know, that would take legislation and that would take things that may or may not occur in the near term. And so then I think what you have seen, and Peter, you've led this at a state level, then I think states and communities with their constituents, payers, providers, you know, innovators are, and you said this, across the country are stitching together, if you will, what's the system, what's the data, the technology, the like basic financing, et cetera, for the underpinning of the system. And then what is the, you know, test, innovation, sort of sustainable financial model that often the healthcare delivery system brings to bear, because we have more dollars flowing through that part of the system to support the change we want long term. I mean, I'd be interested in others' views, but I think in the near term, we're likely going to continue to see innovation at a state and community level, yeah, at the federal level too, but a lot of innovation at the state and the community level.
So in the long-term care space, I guess I would say that particular to home and community-based services, because those services really rely primarily on Medicaid as the first and last and middle payer. You know, I think one of the challenges that delivery system has faced is, you know, is this inequity in financing, in opportunity? I mean, federal initiatives that have encouraged expenditures and the development of IT infrastructures, quality data systems, data collection, the ability to even, you know, capture and measure and manage data is very sparse in much of our HCBS system, right? You've got to remember that this is a delivery system that in large swaths of the country are small to medium sized nonprofits. There's consolidation that's going on at the local and at the provider level. And as I said before, this is really in its infancy. So from the perspective of that group of organizations and providers and structure, I think that there does need to be state investment. There does need to be federal investment. I think that the 10% EF map that came through on the ARPA that is providing states with an additional 10% for all their home and community-based services. I'm seeing a lot of interest in states in using some of those funds to make those kinds of investments because they've never had a tranche of something like $13 billion to be able to address that set of issues. Now, that being said, the competing pressure will be that workforce piece, because even if we have the best data system in the world, if we do not have individuals who are willing to do these jobs in a field where we're seeing anywhere from 40 to 80% turnover, we are not going to make it very far.
Let me ask that. Let me build on that and ask you, Piyush, and Patrick, actually, because it's a really great question of how much time at Cityblock, but also at Optum, do we spend with the timing and resources, right? Because both what all of us are saying, and I'm going to come back to I'm building up to the question that you all can see in the chat around how do we change human behavior, but I'm building up to that one. But how do you think about training the workforce, providing them the supports and resources, and then the sustainability of that workforce, right? Because it's a both high tech, high touch approaches that you're talking about, whether it's in long-term social support, behavior, all of the issues that the three of you raised. So what's your approach to training and supporting those, providing that infrastructure and scaffolding and training, and to sustain that workforce to bring about the changes you all are achieving?
The foundation of Cityblock is built on the community health worker model, which is different compared to a lot of other potential clinical models you might be thinking about or exploring, right? So having smaller managed populations within a cohort of your community health worker, so you can, again, build up that relationship-based medicine, right? The interactions that you have to build up the trust go way beyond what we should be thinking about in clinical medicine, right? Engagement is a science, and that science is addressing needs where they are, making sure that people feel heard, making sure you have motivational interviewing skills. So to go along with your question, right? It's how I flipped it. I went to sustainable first and not training. But if I was to think about training, it's motivational behavior, motivational interviewing, make sure you have all the skill sets of their community health workers to scope out clinical signals. We call them signals or red flags in a patient's otherwise life, whether it's medical, behavioral, social, and making sure that those signals, when they become big enough, are then flagged to your clinical team. But to make sure that this is sustainable, the reason why you have a much larger community health worker force is to not overwhelm your teams, right? So I need a lot more boots on the ground that are engaging our members at a more frequent basis, but not having to worry about 1,000 members, a community health worker. I hope that answered that question, and now I'll turn it to Patrick.
Yeah, so, a couple thoughts. I do think this sort of we think of it as what are the sort of teams we're going to put together, from health workers to social workers to mental health professionals to, how do you engage the caregiving team for a family? So, I mean, it's interesting. We actually think about this more than you might think. I was with one of our mental health team yesterday, where our primary barrier to providing the care we need is how do we recruit and retain therapists at a scale, like we've got thousands and we need thousands more. So, how do we put them in a system that they're able to maximize their ability to do what they want to do best, like deliver care. Same for primary care docs. We talk about this all the time. How do we surround them with a care team that enables them to do their best work, care for populations? I saw the duals question. We training for somebody we have a lot of people going into homes. It's a different training model that I didn't learn in med school. Maybe med school's evolved, but they didn't teach me that. So how do we train a care team that's going to be in someone's home 9 times a year? And it's certainly, it's not just clinicians, it's health workers, it's, virtual technology. So sorry, Peter, it's I want to be brief because I want you to get to multiple questions, but there's a few thoughts for sort of the training and team component.
No, and I think that's terrific. And I'm going to flag for our National Academy of Medicine folks, that is a recommendation to think about. It's not just about money, it's workforce. I mean, you heard that 3 times from this panel, like loud and clearly, that whatever payment model we need people who accept that payment and are providing the level of service we want. I'm going to switch gears a little bit and ask about the accountable health communities. Patrick, you talk about this as a promising new model. In California, we call it CACHI, the California Accountable Communities. There's flavors across the country. And what I love about it is it's emerging organically in some sense. People yes, it came from CMMI, but it's happening. So thoughts from the panel, 'cause all of you, I think, have some thoughts on this about what would be a payment model that works, that blended payment model. We talked about blended and braided. And then what about that return on investment, the cross-sector investment, maybe longitudinally? How do we think about that? I know Neil and Nathaniel are working on payment models. Neil Halfon about 5, 6, 7, and 8. So the HCP land, what's that look like? But if you could address what you think, where do you think that's headed?
Yeah, I'll start and others can jump in. You know, if you could do this legislatively, what I've thought about, but you need legislation to like literally skim a tiny bit off the top, if you will, of every healthcare delivery dollar and think about how you invest that in. So that's one concept. There are ways you could maybe get that at a federal, state level or close to it, by the way, that I think would be more nuanced than what we do today. Does that make sense? So you literally take some and you redirect the dollars either at a federal or state level. Accountable health communities, I worried about this when we were doing it. Like the evaluation was going to be really hard. The sustainability was going to be challenging. I think I saw Jan was one of the questions, so she knows this. Still was the right thing to do, to your point, Peter, because you're helping to spur or add on, it was the hypothesis, which I think has played out, a level of sort of innovation and testing at communities that you learn what works, that the goal then that drives to more sustainable financing models. I'm a natural, optimistic, hopeful person, so I think there's still promise there. I think, you know, North Carolina, it's not, you know, Mandy and I had both come from that CMS environment and tried to apply those lessons in North Carolina. Obviously, you in California have applied all kinds of learnings that we all learn from. So those are my few thoughts.
Yeah, I'd agree with that, Patrick. But it's an interesting dance at that federal level to make that happen, which still, you know, sitting on the sidelines, observing and eating my popcorn.
I'll finish with the one that we all want to know, the $4 trillion question, which is how do we work with individuals to get them? I think you guys you've touched on it, but to get that behavior change, right? This comes down to people taking responsibility for their health and facilitating that. And it feels like all of your models are there, and you touched on the barriers and enablers. But if you had to pull out and distill for the recommendations, I mean, I heard trust, I heard some other things, but how would you? And this will be a little bit of your closing comments about how do we move toward that individual community change, but also behavior change, and then also in a community or in a setting. So maybe we'll start with Sharon, and you can kind of make this your. What do we need to remember? What do we need to think about if we're going to actually achieve that? Because I think that is so central to improving health and well-being.
So absolutely, and I completely agree with the comments that have been made about the importance of relationship and engagement, and in particular in the long-term service and supports space, because we are really talking not just about holistic systems, we're talking about holistic lives in terms of where does someone live, who do they spend time with, what do they get to eat, how do they move around in their lives in terms of transportation, do they have the supports that they need if they want to choose to participate in the workforce. And so having the opportunity to have that, you know, whether it's a community health worker model, a robust supports coordination or supports navigation structure, I think is absolutely critical. And I know we've done a lot of work around care coordination, especially as it relates to the intersections between medical and post-acute, and we often focused on those moments. But when we're talking about the long-term service supports population, I think it's the thing to remember is that for these individuals, the connection with system is daily. For many of them, it's hourly, and for many of them, it's lifelong. I mean, I just had to chuckle at the idea of, well, we see people 9 times a year. I mean, the people that I'm most often working with are seeing people every single day. And the only way that that will work is if it is relationship based and there's trust.
Patrick, do you want to go next? Or?
Sure. Yeah, I mean, since it's closing comments too, I think one is, we have people that are falling through the cracks in our system each and every day. So I think the challenge for all of us is how do we move faster to provide care that's highly reliable, and so that less, or someday hopefully no, people fall through the cracks. Related to that, especially, it's always been true, but especially evident in today's world, is health equity and issues that couldn't be more stark in the need for us to move towards solutions. The other thing I'll say, I've been saying this a few times recently. About 15 years ago, in a somewhat crazy time, I said, I think there's 3 places in America, and this may not be right, but I was like, I think there's 3 entities in America that could change healthcare, which is, one was CMS, one was the Blue system if it actually ever acted like a system, and the third was United Health Group. So for better or worse, I'm on my 3rd try. So if I don't get it right here, I don't know. I just I guess I'll retire. Our system has the resources, but it's how do you redirect those resources and deploy them equitably into the populations that you want and need to. And I think, it's very evident we've got work to do there. On the behavioral, the one other thing I'll say on behavioral, it's a pivot from your behavioral. All of our mental and behavioral businesses report into me now. I was with that team this morning. We provide behavioral and mental health care benefits to over 40 million people, and we just have to do better. It's got to be a more accessible, evidence-based, integrated into primary care system for the full spectrum of mental health. And so, just to call that out, I think we've got a huge opportunity there to build a system that's much better for the people we serve.
Yeah. For me, to go along with that, and I completely agree with both of you, it's creating those delightful, memorable experiences, right? So just a different way to frame it. Access is a great example. We might have, let's assume, even in an ecosystem, I'm currently in Phoenix, let's assume in Phoenix, I have enough MDs, NPs, therapists, and everyone else to take care of the perceived population of volume that I need to take care of. But if it still takes me 2 hours to get an appointment because of front door or access to getting in the EMR or whatever, you've eroded all of my trust. So my point is, it's not just about access in terms of the number of people to the population. It's purely about the overall experience, which it's just, there's not been enough focus on that, right? So when I start building trust, is it delightful? Is it memorable? I'm assuming, Patrick, I'm looking at that beautiful painting behind you over your left shoulder. Someone drew that, I'm assuming, and probably with some families or some patient of yours, and there was a delightful, memorable experience there. That's the level of trust you need to build, right? And so think about that as you're designing your next healthcare ecosystem. Thinking about that as you want to transform care, because it's too much about we need to hit this metric of reducing cost of care.
Thank you all. I mean, I think that exceeded my expectations. And what I want to, before I turn it back to Keisha for the next panel, first just say thank you and appreciate that you are not just speaking with and sharing your lesson, but you're living it every day. And I also appreciate we're not always honest in healthcare. Like, we don't always say people are falling through the cracks or Medicaid is not the optimal system, even though we all depend on it. So I actually really do appreciate your honesty, both of things that are working and things that are not. And then I just would finish with just the call to the humanity that each of you had. Yes, this was a panel about payments, but really this is about a panel about people, right? And this is a panel about doing what's right and things. So I just think that framing, we didn't lose sight of we have to pay for care and there are transactions that happen. But what I really appreciate is that you framed it in the human condition and how we have to be more human. right? And really achieve that. So just thank you for your honesty, for your insights, and you will show up in day 3, I promise, in the writing as a committee member. And I will, with that, thank you, and turn it back to Keisha to turn us to our next panel.